All right. Welcome back, everybody, to this episode of Beaveman and The Doc. This is number 5. I am the Beaveman.
And I am the Doc.
All right. So, Doc, how you doing, man?
Tired.
All right. So, tell me what you've been up to.
Well, it was a long drive to get here.
What did you drive on?
Well, let me see. My car has a bad fuel pump, so it's in the shop. So I got no car. I took a two-wheeled vehicle.
A two-wheel vehicle.
So you got no money, so you got no car, and you got no woman, so there you are.
Right?
Yeah. Not really.
Well, not really. So a two-wheel vehicle, we're talking like a 10-speed, a severe mountain bike, perhaps a hog.
Like a Harley?
Yeah.
Oh, hell no. Right. I wouldn't own a Harley even if I could afford one. They're crazy expensive, high maintenance, and way too loud.
And they get oil all over your garage floor.
That too.
They don't always start.
So, no, I went with the moped variety for the day.
Now, whose moped is that? Is that your moped?
Well, it was supposed to be for the kids, but since they're not using it, I figured, what the hell?
How often do you ride a moped, would you say? Mopeds are awesome.
Not including today?
Mopeds are awesome.
I try and start it up and drive it around a little every couple of weeks.
Okay, gotcha. That's pretty cool, though. Mopeds are cool, though.
Yeah, cool. Well, you know what they say. They're fun to ride until your friends find out about it.
Yeah. But the problem is, we don't live in the city. So you got to go a distance to get places.
I had to take it to school today.
Yeah, you're farther away from your school than where I'm located. So how long did it take you to get there on the moped? You had to go on the back roads, too. You can't go on the highway with that.
No.
Yeah, so you took the back roads, I assume?
Well, to school, it's all back roads to school. In fact, it's only, 5-6 miles to class?
Oh,
it's not that far.
Where do you go? I thought you went to Valley.
No.
Oh, you went to...
No, it's like... Valley's like a 40-minute drive in a car.
Right.
To where KCC is just right around the corner, metaphorically speaking.
Sure. Okay. Well, that's not too bad, then.
It took me about a half hour to get here.
All right. Well, for those of you that don't know, although we explain it all the time, the Doc is not a doc. So...
Could be.
He could be someday. You never know. Or whatever.
If I live that long.
Yeah, that's a long, it's a long route. All right, so today, as promised, what I'm going to do is I'm going to talk about a topic that is near and dear to my heart, and that is the healthcare system in America. There are so many things wrong with the healthcare system in America that I could talk every day for the rest of my life and probably not cover all of it. And of course, as anything else that we talk about with Beaveman and The Doc, it's all opinion. So if you don't like it, you can disagree with it. If you disagree with it, you disagree with my opinion or Doc's opinion, who gives a shit? It's then fuck you, basically. It's our opinion, we're right anyway. Anyway, because that's what opinions are,
It's my opinion, get your own.
That's right. So what I'm going to do is I'm just going to talk, and it's going to be fun. Trust me, it's not going to be just this boring. This isn't Dr. Oz bullshit, or not that I've ever watched Dr. Oz, nor will I ever watch Dr. Oz.
Dr. Phil and Dr. Spock. And
yeah, who knows if any of them are actually doctors in the first place. So without going into too much detail, let's just say that I do work in healthcare, so you are getting an educated opinion, but again, like I said, it's my opinion. It is I would say it's mostly against the mainstream. So if you take regular education, you've got these people, they get out of high school, they go to college, they get their undergraduate degrees, they decide that they're going to get an advanced degree. Maybe they're getting a master's, maybe they're going to get a doctorate. And their doctorate might be medical doctorate. It might be, doctor of osteopathic or whatever medicine. Could be in nursing, could be chiropractic, could be naturopathy, whatever. So you have all these different providers out there. They've got different types of schooling. I don't like to speculate too much on what their schooling was. I only speculate on how I was trained because, of course, if I haven't experienced anything else, how can I truly speculate on it? You got to have that firsthand knowledge. what I can tell you is based on my years of practice and based on my interaction with people who provide healthcare from the different, what I call the different branches of healthcare. For example, nursing is its own branch, medical doctor own branch, osteopathic, whatever. That's their own branch, you know. And they
They need to have a
interact
branch of
with each other.
healthcare to teach you how to be a patient.
Well, yeah,
Because,
they
I
teach
mean,
people how to be informed.
Think about it. I mean, there's a lot of decisions to make, and then navigating the paperwork and the billing and everything like that. It can be a nightmare for somebody who isn't familiar with it.
No, for sure, and that's all stuff that goes back to very early on. You know, people need to be having those conversations with you, and we're talking about grade school, and that goes right back to your your health classes, and it goes back to even home ec. You know, where really what we want to teach people is we want to teach them prevention. We want to teach them to not end up getting ill. Now, I will tell you that the regular model that we follow here in the United States, truthfully, is treatment of cure. Or what we would do is we're waiting for you to get sick. We're waiting for you to get sick so we can treat you. It's not, let's prevent you from becoming sick.
And cure you if you do.
Exactly. That's not what it's like. Well, all we're waiting for you to do is we're literally sitting back waiting, oh, let's get some sick people today. Let's treat some sick people. And typically speaking here, if you are sick or if you have a chronic condition or if we determine that you might have a chronic condition or even just a symptom, how do we, you as a consumer, Doc, how are you usually treated? What's the treatment of choice usually that you've experienced if you've had any medical illnesses?
Antibiotics, painkillers, the typical, or they just say, come back if it gets worse. Right now, there's nothing we can do.
Okay, yeah, and in general, that's a pretty decent rule of thumb. It's what we call watchful waiting, which is fine. I will tell you that a lot of times, what do they usually do is they usually throw a medication at people. And it's really, we're basically at, it's an epidemic, really. There's recommendations that are put out to all providers at all times, constantly, just constant recommendations that are just not followed. And one of the biggest recommendations you see all the time is stop treating everything with an antibiotic. And that's a whole different area of conversation that really just gets me pissed off all the time, is to see people that have a clear viral illness and they get an antibiotic. I've seen people get antibiotics that are designed for, basically 5 days, and not only do they get that, but some knucklehead asshole fucktard gives them a refill on it. So now not only did you just treat that virus with an antibiotic, but you also gave them a refill. How fucking stupid are you? Anyway, you can see how pissed off I get about this shit. All right.
Isn't that how mutations happen anyway?
That is how resistance builds, and resistance builds because of a mutation, exactly. So the bacteria or the virus or whatever, and in this case, because you didn't have bacteria anyway, and viruses are just really fucking hard to treat, all you're doing is, one, you're killing off that person's good bacteria, and you're helping other stuff that it comes in contact with that is common in the community, and you're helping it mutate so the antibiotics that we're having no longer work. Now, medicine is a huge industry. It's all about the dollar. I hate to break everybody's fucking heart, but it's all about the dollar. Now, you might encounter people in medicine, in nursing, in therapy, physical therapy, rehabs, whatever, that are not about the dollar. There's a lot of them out there. But the industry itself is all about the dollar.
I know there's no real money in antibiotics anyway.
Exactly.
That's why, when was the last time you heard about a new antibiotic?
Yeah, you don't. And
because there's no money if you cure them of the problem. You make money by treating the symptoms of the problem. If you give them an antibiotic which actually cures their problem, then you don't get to string them along for tens of thousands of dollars and overpriced pills and
exactly. And you just made another point there, and the reason why there's no money in antibiotics as well. How often does somebody need an antibiotic? So you're talking about a 5-day course, 7-day course, 10-day course, 14-day course, or whatever. Why develop an antibiotic that's used short term and is only going to make money in that short term when you could have somebody that needs a blood pressure medicine? They need new technology for, controlling cholesterol or for a seizure disorder, etc.
How do you identify when an antibiotic is needed? You have to do
That
blood
is-
tests, right?
No. It is based on clinical presentation. So, for example, there's different areas, right? So if you work in an area like you work in family practice or you work in internal medicine, these are patients that are in already part of your patient load. You know these folks, so when they come in with a problem, you assess them clinically and determine if this is a bacterial illness, if this is a viral illness, maybe it's a fungal illness, etc. And then you treat based on those symptoms. Now, is it 100% accurate? Not necessarily, but the beauty of working in family practice or in working in internal medicine is I know this person, I can start treatment or do watchful waiting, and that person knows, and it's reinforced by you that, hey, if you're not better in 48 hours doing what we're doing, or you're not better in 24 hours, or you just feel worse or whatever, come on back. And then I'll determine if I need to do extra testing or whatever. The reason why you do that is because lots of people are not going to go get these tests that you have done. If you say, well, this could be pneumonia, I'll tell you, I've done a lot of work in like rural clinics, and I had a really hard time of getting people to go see specialty care providers. For one, they didn't trust them. Small community, didn't want to go to the big city, didn't want to see people, and they only wanted to see me anyway. So if I thought somebody had pneumonia, the way I was taught was you don't order tests unless you know what the result's going to be.
Or at least you think you can.
Or you have a really high suspicion of it, because what is it going to change your treatment that you're planning anyway? Is the person going to go? Now, in family practice and internal medicine, you have that luxury of getting those people back. You can call them, you can whatever, because you know those people, those are your folks. When you look at people who go to primarily to urgent cares and ERs for their treatment, they overtreat. And part of that thought process, you can see some of the reasoning behind it. Part of the thought process is they're like, well, this patient may never go see another person. I'm just going to treat them just in case. So even if I suspect it's a viral illness, I'm going to give them an antibiotic in case it's bacterial. You also see this just big waste of testing. We used to call that, when I worked in the emergency room, we used to call that the shotgun effect, or the shotgun method that the emergency room doctors would use, where they would order every freaking test under the sun until they found something that might be slightly wrong, and then they treated it. Now, you want to talk about wasted healthcare dollars? You don't do that in family practice. You don't do that generally, when I worked in internal medicine. And I personally don't do that even when I've worked in the ER and in the urgent cares. I did not order a shitload of tests. And this is where I would butt heads with other people, because they're like, well, you should order this, 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 and this. And I would say, I don't suspect that. They don't have the symptoms for that. If I actually thought they had the symptoms for that, what's the point of me ordering this test if it doesn't change my treatment or what they actually have? So
I think it's better,
money,
rather than ordering the test, you send them to a specialist who might have a better idea of the problem, so they can order a test without wasting a whole bunch of time.
Well, there's different ways to think of that too, because if you're going to send somebody to a specialist, you do want to do footwork for them first. So you're talking basic footwork that you want to do for them, because you can treat everything, most stuff in the family practice realm, which is mostly where I like to work. And if I get to a point where I'm like, yeah, I think it's something else, but I've done all this groundwork. And when it starts getting to stuff that, tests that, I wouldn't normally order, then in conversation with the person that I'm sending them to, I would say, is there anything else that you want me to do first before they come to see you? Or do you want to see them first and then determine? And generally, once you've done the very basic labs or the basic imaging or whatever, beyond that, then the person that you're consulting with will take it from there. So yeah, exactly. You don't want to waste money ordering some test that they never needed in the first place or isn't going to tell them anything. But that's healthcare in general. Why am I ordering stuff that you don't freaking need? Why I'm going to go look for something that you most likely don't even have.
I think insurance has had a real negative effect in that sense, because if you think about it, some doctors they since they feel that it's not costing the patient anything, the patient's not going to mind having a whole bunch of tests run, so they send them to have it done. Hospital gets a whole lot of money. Doctor probably gets a fair amount of money from doing those tests too. But the only one that supposedly gets screwed is the insurance company.
Well, the insurance company's not getting screwed because they tell say you order a test. Say I order something. I want to check your cholesterol. Okay. Let's say that test costs $20. All right. They're gonna order it. They're gonna charge the insurance company $50. Let's say that. Okay. The insurance company is gonna say, no, this is what we're paying you for it, and that's what you get. And prices by insurance companies are based generally off of what Medicare will allow. So they base most of their stuff off if Medicare is telling you that they're only going to pay $12 for this test, that's all the insurance companies generally going to pay also. So the insurance companies are not getting screwed. Any problems that the insurance companies have with getting money or whatever, they pass on to the consumer. They're not getting screwed either. The only people that are getting screwed are us, the consumers.
That's why I had a bill that was $168. The insurance company pays about half, and then I get screwed for the rest, even though my policy says 80-20, and it's more like 50-50.
Now here, this will piss you off a little bit more. So on that same line, right, let's say you don't have insurance, and you want to have your cholesterol checked, and I'm just picking, a cost of a test out. This is not accurate. I'm just using it as an example. Let's say you don't have insurance, and you want to have your cholesterol checked. So you go to an independent lab that has a medical director, so you don't even have to have a doctor order this test for you. And you say, I don't have insurance. How much would it cost me to get a cholesterol panel done? $6. So
it costs more because you have insurance.
Exactly.
The paperwork's a freaking nightmare.
It costs more because that's how it's all set up. It's all about the dollar. So that independent lab, they still made money because they're going to send, they don't actually run the test themselves. They send it off to another lab, but they contract for prices. So they're still going to make money off of cash-paying patients. How much more fucked up is this? If you've got a high deductible, you're already paying for insurance, but you've got this let's say you got this $6,000 deductible that you have to meet. Well, you're still paying for your doctor's visits every time you go until you meet your deductible.
Yep. I remember we talked about I'm trying to remember, it was a couple of years ago. You and I, we were talking about the idea where it's like a membership where all the patients, they sign up with one doctor. That's the only place they go.
Yeah, you're seeing them pop up, but even here in Michigan now, you're starting to see that pop up, and it's a great plan, and that's what I always said that I would do too.
They don't accept insurance.
Yep, that's great. Because even if, for one thing, you're more likely to keep your patients out of the hospital. When I worked in, rural clinic where I had, this population of patients that didn't want to go anywhere in the first place, they had my home phone number. So if they got sick, they would call me and they'd say, hey, Beaveman, should I go to the hospital for this? And I'm like, no, come in tomorrow, call first thing in the morning, they'll fit you in because I don't want you going to the hospital. Unless it's an emergency or, you've got a chronic condition where I know it's an exacerbation and you're not doing good, then I don't want you to go to the hospital because what happens when you go to the hospital? They charge you a shitload of money. You might not get admitted, so you're going to get this giant ER bill. If you do get admitted, you're more likely to get a fucking infection, or they're going to change all of your medications around because, get this, let's say you're on this medication. This medication works for you. You have to take it for your chronic medical condition, okay? You go into the hospital, there's a good chance you won't get that medication because the hospital has what's called a formulary, and they're going to give you that medication that's related to that medication that's on their formulary.
A few years back, I went in for a heart surgery. I went in needing a heart surgery, and by the time it was done, I looked like I was wearing boxer shorts made out of bruises because they couldn't hit the artery. They tried 5 or 6 times on one side, and by the time I was all mangled on that side, wasn't usable anymore. Then they tried another 5 or 6 times on the other side, finally got lucky and hit the artery. So what wound up happening is they did the surgery, and on my way out, I wound up vomiting from the anesthesia coming out of it. Maybe I didn't wait as long as I probably should have to eat or drink. I'm not sure. But anyway, I wound up having pneumonia.
Because you're aspirated, so you're vomit.
You think that'll do it?
Oh, yeah.
Okay.
or you aspirated a little bit when you were on the table having surgery, even though they didn't knock you out, right?
Yeah, they did.
Oh, they knocked you out. Okay,
yeah.
well, you could have you got tubed.
Yeah.
So, yeah, you might have aspirated a little bit when you got tubed, or aspirated a little bit when they took the tube out when they were rousing you to come back up. And that's why you probably got pneumonia. So you got aspiration pneumonia. That's a common phenomenon. So once again, here you were in the hospital, and imagine how much that added to healthcare costs. Quite a bit. Because you just went from, you just added on another health condition that had to be treated.
Yeah, because they had to have the extra doctors come up and talk to me as well.
Oh, sure.
Trying to explain things to me and hope that I'm not pissed about it. And
yeah, you've got risk management that's coming in and checking on you for sure. So all those things adds up. All that adds up, and then if you want to blow your mind further, if they couldn't access that artery, I wonder how many kits they went through that cost, hundreds and hundreds of dollars before they got in, because I'm sure they're not accessing you every time with the same one.
They said it took them 11 tries.
Well, there you go.
I didn't think my arteries were that messed up. Come on.
More and more money, and where's that money going? And there's so much waste out there. Say you open up, it's better now because a lot of times they'll scan stuff. They didn't used to scan things. ER notoriously wasted things. If say you had to do like an IV start on somebody, and maybe you poked somebody a couple times and you got it in finally or whatever. If you charted, I just charted and said, IV access, obtained. But if I don't put, 2 times or 3 times or whatever, and it's common, or it wasn't scanned like that, that angiocath wasn't scanned, well, we just lost money because we didn't charge for it. I mean, that stuff's not free. So there's loss everywhere. And how do they try to make up for that loss? And this goes into, I'm kind of hopping into it here earlier, but I think healthcare is this big fucking conspiracy to make money for a select group of people, do a bunch of procedures that we don't fucking need, and to just basically make us more of a sheep,
It's a machine.
Is this giant bullshit machine, and there's there's people getting rich, there's people doing things that are completely unethical. You see it all the time. I see it all the time, and that's half the reason why I just have no desire to even do it. I don't have any desire to do it. That's why I've been trying to get out of it forever, because there's a select group of people that think the same way I do, but we are highly outnumbered. And when you're highly outnumbered, you just keep battling, and either you decide you're going to keep fighting and have people that appreciate it, but you're going to be at odds with everybody else around you.
I couldn't imagine going through all the schooling and everything that you've gone through and then not wanting to do it anymore.
Yeah, but that's you reach a point where, for me anyways, you reach a point and you're like, screw it, I'm done. I'm so done. So the example I wanted to give you is I wanted to talk to you in a couple parts. Here's some interesting things. So what I did was I actually pulled up my own labs as an example. So let's say I go into my doctor, because I do see a doctor, and this is the same conversation I have every year, pretty much every year. They go and they check my labs, and a common blood work study that we do is we check someone's cholesterol. Okay. So you go in a normal cholesterol, what they consider a normal cholesterol. They look at a total cholesterol here, and the total cholesterol for me was 202. Okay, 202 for my total cholesterol. What they consider a normal range is between 100 and 200 for this particular lab. Now you're going to have a little bit of variation between labs. It might be 205 or whatever. So that was my total cholesterol, 202. Well, they also look at my triglycerides. Everybody says your triglycerides are related directly to the amount of fat you consume. Sort of. Also related to the amount of sugar that you consume. And my triglycerides were 72, and they like them to be less than 150. Now they look at your HDL, which people call your good cholesterol. Well, I got news for you. HDL is not cholesterol in the first place. So you always wonder why people call it the good cholesterol. It's not cholesterol in the first place. It is a lipoprotein, so it is a carrier for your cholesterol, essentially. Okay? Yeah, you're on meds, right?
I was.
And then they look at your LDL, which they call your bad cholesterol. Again, not a cholesterol. so lipoprotein, okay, and mine was 133. My good cholesterol, or my HDL, which is not cholesterol, was 56, and they want that to be greater than 40. Okay, so when I look at my labs, I'm like, oh, great labs, really good labs. But because my total cholesterol was 202, and that makes it higher than 200, well, I have high cholesterol. So they say, Beaveman, you have high cholesterol. You need to be on cholesterol medication. And this is the same conversation I've had every year for probably the past 4 years. And every time I'm like, oh, I don't have high cholesterol. I have a number of 202. If you're only looking at a number, they're saying that my cholesterol is high. But is it high? No. Even if it's high by that, even if you look at the scale, I'm like, would you consider 2 points over 200 high? No. Now they're treating a number. Now they're not treating the patient. They're not looking at anything else. And this is the problem with healthcare. They treat a number all the time. So my argument every time is, okay, that's not high cholesterol. Okay? And they're like, well, why not? I'm like, well, because my HDL, my high-density lipoprotein is very good. It's above 40. My low-density lipoprotein is slightly elevated. It's at 133. Also not bad. They're going to argue with you that that's bad, but it's not. And my triglycerides, what they call like your circulating fat, is also not bad. So even though that number is 202, my cholesterol is not bad.
Geez, my triglycerides are 138.
Yeah, it's still not bad. I mean,
but that's probably because I drink all that Mountain Dew every day.
Yeah, and people will tell you to cut down on your fat, but really it's sugar that causes the triglycerides to be elevated, generally speaking. Okay, so now I get into this argument every year. So, and now instead of, now I've got more than one doctor. I've got a doctor that I see at the VA, and I've got my regular doctor. My regular doctor is super old, and he's always like, oh, Joe, B-man, you got to take this med. And I'm like, no, I'm not taking it. Oh, you got to take it. And he prescribes it anyway. Even though we get in this big area. And so I don't take it. The last time I saw the VA doctor, he tried the same shit. I was like, come on, man. Let's use our heads. I used to work with a guy, so I'm like, let's use our heads. Let's do the calculator. So now what we got is you've got a heart risk calculator. Okay, or heart disease risk calculator. There's a bunch of them. You've got the American College of Cardiology, American Heart Association, whatever. Okay, Framingham, they did the big Framingham study. So what I did was, I said, okay, what's my risk? So he's like, oh, good point. So we pull it up. So I pull it up. I plug in my numbers. Plug in my average, my blood pressure, my age, my sex, if I smoke or not, and my risk comes out to 4.10%. And this will either be like, over 10 years, over 20 years, over 30 years. Mine is 4.10%. In order for you to have a cardiac risk factor that results in necessity of treatment, it should be greater than 10%. Mine's 4.10. So what did the doctor say? Oh, you're right. You really don't need cholesterol medication. Okay, so that goes again to my point where I say, you guys are treating a number. You're not paying attention to the patient. Now, why is that? Because they're all taught, let's treat a number, let's give this person some medication, let's keep those pharmacy industry going, let's just keep screwing shit up. Now let's say that I did take that medication. Okay? Let's say I took it. Now, is a cholesterol medication normal for our body? Does our body produce Lipitor?
No.
No. Okay. If you talk about cholesterol, let's say, because you're starting to learn this stuff.
If it did, I'd make a fortune because the stuff is extremely expensive.
Exactly. One of the most common side effects that people have or complain about with cholesterol medication is muscle pain. Okay? I will not say that the answer to all of our problems is medication. I will also not say that there's not people that don't need medication. If I was treating someone with heart disease and their cholesterol was high, it's probably a good idea to put them on this medication. But I'm going to talk to them about it first, tell them the risks and benefits. If I've got somebody who doesn't have a history of heart disease, doesn't have any risk factors, and they have this mild elevation of their cholesterol, I'm going to talk to them about it, but chances are I'm not going to give them that medication. Now, here's the real big thing that bothers me the most, okay? If I lower your cholesterol, okay? Cholesterol synthesized in the liver, okay? And now we're going to get to some science. It's because I know Doc loves science. This is going to help.
Chain reactions.
This is going to help you out in the long run, okay? Cholesterol synthesized in the liver. Now, what is remarkable and what people don't understand, and this is why we need to teach people, we got to teach people from a young age, is that your steroid hormones are made from cholesterol. Okay?
So
if
you're talking sissification, for a lack of a better term.
If I take away your ability to have circulating cholesterol and circulating lipoproteins for transport, then theoretically I am disrupting your steroid hormone chain. So let's say I give you that medication. I drop your LDL down. I get this marginal raise of your HDL. I drop your total cholesterol down. Your numbers look amazing. And you feel like shit. And you can't figure out why you feel like shit. And you come to me and you're like...
Because you screwed up the body's natural order of things.
I did. But what am I going to do? I'm like, oh, you feel like shit? Well, what kind of symptoms are you having? Oh, I'm tired. Oh, you're tired. Okay. Well, let's do this. I got to do this anyway. You've been on this medication for like 3 months. I got to repeat your lab studies anyway. So let's do this. I'm going to check your cholesterol again. I'm going to check your blood sugar. I'm going to check your thyroid.
Testosterone is low.
I'm going to check your thyroid, and I'm going to check your testosterone because you're tired now. You're telling me you're tired. How's your sex life? I mean, are you having any problems getting an erection, anything like that? Oh, well, sometimes. Okay, great. All right, so let me check your steroid hormone. I'm going to check your hormones. Now, most people, I will tell you, don't know what the fuck they're doing when they order these lab tests for hormones, first of all. You know, they say, okay, we'll get this done. And you're like, okay, I'll go get it done. And let's say you go get your blood work done at like noon because you had to work that day and that was the only time you had to do it. Okay, so you go get your test done at noon. I get your studies back. You were good, though. You didn't eat. I get your blood sugar back, and your blood sugar is elevated. It's like around 140, 150. It's supposed to be less than 126. So now as your provider, I'm like, oh man, Doc, you got an elevation of your blood sugar. Man, you might be diabetic. And I see you're putting on you're like 6 pounds heavier than when I saw you last time. So this might be pre-diabetes. I think I'm gonna have to put you on some metformin. I have to put you on some medication to protect you, hopefully lose some weight, and see how you do with it. Now, one of the side effects of cholesterol medication, if possible, is elevating your blood sugar. So possibly that could be related. If you gain weight because you're tired, also from that medication, and from disrupting your hormones, now I'm like, well, to protect you, I'm gonna put you on metformin. So now you're on 2 medications. I just put you on metformin, which is designed to lower your blood sugar. Okay, and I got your cholesterol. I got your testosterone back. I got that back. It was low. So now your testosterone's low, and I think we need to treat that. I think I need to give you testosterone. We gotta bring that up. We gotta get that so you're feeling better. Now, I'm thinking in my head as a provider, and this is not how they think. I'm telling you because I've taken care of lots of patients over the years and interacted with people who've come to me because of these issues and seeing the treatment that's done. My thought process is like, hey, knucklehead, what did you just do differently a week ago that you weren't doing 2 months ago when you were basically fine? Well, I just gave this person this medicine about a couple weeks ago or whatever, and now they had this change. Now their cholesterol's better, but everything else is worse. How did that happen? And testosterone is at its highest in the morning, so it will go down throughout the day. So if you didn't get it tested, before 9 o'clock in the morning when it's at its highest, so if it's low before 9 o'clock, then it's most likely low the rest of the day. But if I got it tested later on in the day, Of course it's going to be lower, but I'm going to give you that hormone because I didn't pay attention to when you had your blood work done.
There's common everyday proof that testosterone is highest in the morning. Morning wood.
Oh, there you go. There you go, right? So now I'm like, okay, and, you know, you as the patient, you don't know anything. You're like, hey, you know, the doctor knows everything. You're right. Go ahead and give me the testosterone.
I still hesitate. Like, my doctor put me on blood pressure medicine. And at the time, I was under extreme amounts of stress with my job. I mean, they were working me 60, 70 hours a week. And, well, it's a long story. I don't want to get into it. But basically, I was under a lot of stress. So I started taking Metropolol, sorry. I often pronounce it differently.
Pronounce it everyone. I know what you're talking about. It's a beta blocker.
Yeah. So I've been taking this stuff for a few years now. And it seems to be doing a really good job. My blood pressure is even now. But the problem is I often wonder, had I not started taking that, would my blood pressure have gone back on its own? And am I stuck taking this stuff for the rest of my life now?
Well, but the thing again is, you know, without getting into too much detail, is you take that medication not just for your blood pressure. You take it to regulate your heart rate also. So
Yeah.
you're taking it for more than one reason. You've got a history of, you know, an arrhythmia.
Yeah. AFib.
So standard of care for you is to give you something to kind of help with that also. Because theoretically that's going to keep you from being at a high rate of AFib. What we call, you know, a rapid ventricular response, or, you know, AFib with RVR. So there's a dual reason. The other reason why when your blood pressure was really high that they put you on this blood pressure medication was also what we call cover your ass. If you've got somebody who's getting, you know, and you don't base it on one reading. You know, if you come in and your blood pressure is high, I don't say, oh, I got to put you on this blood pressure medicine. No, I mean, I maybe I prescribe you, you know, automatic cuff. You check it at home, you check it at Kmart, whatever, Meijer, whatever, and you come back and you show me your readings, and then I check it again. So I'm checking it a few times to ensure that it actually is high. If it actually stays high and is sustained, then I slowly lower it over time.
Now that you mention it, the Metropolol wasn't the first thing they were giving me. I don't remember what I used to take. But I took a different medication until I started having the AFib, and then they switched it over to the Metropolol right around that time.
Now, here's the bigger question. Did that medication cause your AFib?
I have no idea. I don't think so, but I mean, I drink a lot of Mountain Dew, like a 1 liter bottle almost every single day, and that, you know, for a few weeks you're fine, but after a while I imagine that's got to start taking a greater toll on you than...
It definitely doesn't help. It definitely does not help.
I know people who drink more than I do, but everybody's different, you know what I mean? So it's going to have a little bit worse impact on some than others.
Yeah, that's just a horrible, horrible thing to do to your body. I mean, I could go on and on about that one, but... So back on topic. So now I've got you on... How many meds have I got you on now? I've got you on 3.
At least 4.
I got you on at least... Oh, yeah, I see. So we got one for your cholesterol that we started off with. Well, your cholesterol is looking better, by the way, though.
Gee, thanks.
I've got you on a medication for pre-diabetes, which is the metformin, because I don't want your blood sugar high. I'm not saying that you had diabetes, but if you got a little bit of an elevation of that blood pressure also, because you're already on that blood pressure, well, you've got metabolic syndrome. So I got a new diagnosis for you, too. That diagnosis code is going to bump our office visit up also to a higher level, so I'm going to get paid more for that, too. So now you got metabolic syndrome, because you got that impaired fasting glucose. You've got hypogonadism. We're going to treat that with some testosterone. You got hyperlipidemia, which is your cholesterol issue, or dyslipidemia, and then you've got you've got that high blood pressure issue that you've been treating with your arrhythmia. So wow, in 15 minutes I've made a pretty decent amount of money off of you, and now I've got you going on some more medications. Now I don't care about your side effects; I just care about your numbers. So we're gonna put you on this testosterone.
Oh, there are gonna be lots of side effects.
So I got you on this testosterone. I've got you on the metformin. Next time I see you, I'm like, so how are you feeling now? Well, I'm still tired. Oh, still tired, huh? Maybe I need to bump that testosterone up. Now, without having even adjusted anything, you decide, maybe you're like, fuck this. if you're smart, you're like, fuck this. I need to figure this shit out. Okay? And because you know me, you're like, hey, dude, well, tell me what's going on here. You're an educated guy. So I'm like, okay, yeah, I'll give you my opinion. It might not be the one that you share with your doctor, but here's the rub, okay? And for people who like graphics, I got a little graphic for you.
Oh, nice.
Now, as I told you before, cholesterol, super goddamn important, okay? Our cholesterol, broken down in the liver. We've got enzymatic processes, right? We've got enzymes that break things down. Stuff gets transported through our blood by, carriers, like our carrier proteins or whatever. I'm not getting deeply into the science because I don't need to get deeply into the science because I'm not a biochemist. However, basically what I'm telling you is this. In the liver, our body takes that cholesterol through synthesis. It makes pregnenolone, okay? Pregnenolone is just like our mother hormone, you can say that, okay? It does get utilized by other tissues throughout the body, but generally what happens is pregnenolone gets broken down by other enzymes, and it goes here, down the different chains, right? So and now, once that gets broken down and utilized by our tissues, or it's going to be taken to those different tissues, and it's going to be matched up with receptor sites, and enzymes are going to break everything down, and you're going to get your hormones, okay? But if I lower this, theoretically I'm going to lower this, okay? And then everything else down the cascade is going to get lowered. And you can see as we break things down, pregnenolone is the mother hormone, so when that gets broken down into DHEA, androstenedione,
Everything beneath it on the
and
tree.
down here's our testosterone, okay? So you can see that it's very possible that I disrupted that. It's also possible that something happens with the conversion here, and instead of utilizing that testosterone, it actually got broken down into estrone or estradiol and then broken down, and now you actually have more estrogen than you had before. So now not only your testosterone might not be low per se, low secondarily, because now actually maybe you're actually making more estrogen or keeping more estrogen and not keeping the testosterone like you're supposed to. So I just decided that as your provider, I'm like, well, I'm going to give him testosterone. If I give you testosterone, now I have shut down your body's need to make testosterone because you're getting testosterone. So when they say people are on testosterone for life, that means that, is that true? I don't think so. I don't think that's true. They're on testosterone for life because I'm giving it to you and I've shut down your body's ability to make that testosterone or need to make that testosterone so I'm giving it to you.
So it can come back.
Sure. But in order for it to come back, I would have to withdraw your testosterone. Is it going to be low for a little bit? Most likely. Will it come back up? Of course. But it's going to come back up through lifestyle changes, and most likely in this case, I would say, unless you absolutely needed the cholesterol medication, I'd probably get rid of that, or I'd change it, or I'd lower the dose, or I'd have you do it every 3 days, or whatever. In your case, you've got that rub, and you're like, wow, man, he really probably your cardiac risk factor is so much higher than mine, obviously. For me, whether you would look at it and say, I wouldn't even go down that road, he doesn't need to take it. For you, probably need to lower your cholesterol. And not only are they doing it because they're trying to protect you, but if anything ever happened to you, there's a good chance that if they never had the conversation with you and they never documented that you said, you know what, I don't want to take that medication, there's a good chance you would sue them later, or somebody else would sue them later because they didn't, quote, follow a standard of care by putting you on that medication. Medicine now is so into defending themselves and covering their ass that they're doing things that I consider unethical because they're only doing it to cover their ass. And why do they have to cover their ass in the first place? Because of poor practice 20, 30, 40 years all up to this point. Because
then why can't the doctor just explain, look, this is the way the system works, so I'm supposed to recommend that you do this. If it were me, maybe I wouldn't, but it's your choice.
Well, what they're supposed to do is have a conversation. Healthcare, primary care, whatever, is supposed to be centered on the patient. It's supposed to be like a little hub. You're the center of the hub, okay? I'm out here. I'm one of the spokes, or part of the wheel, rather. And then maybe you've got a cardiologist. He's a spoke. Maybe you also see, a psychologist. They're a spoke. Maybe you
'cause
see
I'm crazy.
maybe you see a physical therapist. They're part of your spoke. So that's centered on you. We're going to give you all the information. We're going to have these discussions. We're going to talk about stuff with you. But the ultimate decision is yours. But you want to be able to make a decision that's informed, not one that I told you to make. Now, is everybody interested in doing that? No, because lots of patients don't give a fuck. They're just like, oh, just give me a pill to fix it. Well, it's not fixing anything because you don't understand what you're doing. The next thing you know, that person's on 10 pills. Just like the example I just gave you. Next, you come to me and you say, I'm shitting all the time. I have loose stools all the time. Well, common side effect of immediate release metformin is loose stools. Now, if I decide that's what the issue is, then I say, okay, let's put you on an extended release one. A lot of people do pretty good with that one. But that is a common sign of immediate release metformin. But guess what? Most insurance companies don't let me put you on extended release first. They have to fail on the immediate release one in order for me to do that.
What's your feeling on generic medications versus name brands?
They're fine.
You think they're
the only
the same
difference,
thing, pretty much?
The base component has to be the same on all of them. But they have to, all medications, in order for them to be different, they have to be different chemically. That's how you are able to manufacture something. So your generic metformin or your generic, glucophage or whatever, the generic is not identical to the name brand. It can't be, because then you can't have that patent for it. It can't be identical. There has to be something that's slightly different, whether that's a dye that they use or the filler that they use or whatever they use. But the actual base medication that they use is the same. And it's like anything else. If I give you the generic version of this and you don't do well with it, but you do okay with the brand version, then I'm always going to write for the brand version. Because you might not respond okay to some of the additives, fillers, whatever. And that's normal, because that's a normal species issue. We get sensitive to things.
Like Viagra, everybody knows one of them little blue pills, right? So the generic brand of Viagra probably isn't blue. And that could be the only difference.
Yeah. The shape, it's going to have a different symbol on it. It might have a different additive to it, like they use the sugars or whatever they use as the basis. But the actual key component or the actual chemical configuration that makes that medication is the same. It's everything else that's different.
I had to mention Viagra. Everybody likes to talk about Viagra.
And lots of people like to talk about Viagra, but now, because of all the medications we got and because we disrupted your steroid hormone chain, most likely you probably do need Viagra, and I'm probably going to have to give you that. But you're not going to like it because your insurance might not cover it. So anyway, as I talk about the breakdown of the hormones, the thing is that, like I said, now we've shut off your ability to make that testosterone. When I could just sit there and actually have the conversation with you and try to figure out why everything is breaking down.
So what would happen if there was some apocalyptic event and I no longer had access to all these medications? Then I just, aside from some detox that might happen, I don't know how addictive any of those medications are, but let's say a meteor struck and now society is gone and you're just out there trying to survive. How would this guy that you're treating here survive without those meds?
I would say probably, well, of course, you can't predict 100%, but because the big thing with this one is, the arrhythmia. But having said that, I think that the majority of illnesses that we encounter are specific to where we are historically. In other words, what we directly put into our mouths, what we eat, what we drink, the sedentary lifestyle. Obviously, yes, genetics plays a factor in all of that, and if you have a genetic predisposition, you're going to die off. Okay?
Oh.
If you don't have that, and it's because it's of everything else, you're probably going to get better.
Post-apocalyptic guy, he also wouldn't have the excessive amounts of caffeine.
Exactly.
He'd be more active because
Yep.
he's looking for food.
Yep.
He wouldn't eat as much.
Mm-hmm.
Well, because there's not as much to eat, obviously. Let me see. As far as the sex and the Viagra, well, I imagine he's probably not going to be doing a whole lot of that either. But it's not that he can't, it's just he can't find somebody to do it with.
Well, but now he probably has the higher desire because now he's burning 4,000, 5,000 calories a day. He's getting lean muscle mass. He's getting rid of that extra, what we call adipose tissue, which is fat. And guess what? Extra fat, you know what hormone that makes? It makes estrogen.
Ah.
Another reason why that estrogen level is high and your testosterone level is low because
Something I
you're
won't learn
kicking
till
up.
next semester.
And now you're not fueling up your moped all the time either. Because when we fuel up our moped, we're still exposed to those fumes, which also are estrogenic. So there you go. So when I talk about environment,
So the
when I
end of
talk
the
about-
world might have been the best thing that could happen to this guy.
Maybe, because now he's burning more calories, he's got more lean muscle mass, and like I said, unless he has that genetic predisposition, there's a good chance that the arrhythmia goes away, the blood pressure comes down, the cholesterol gets higher, but it's not bad because he's synthesizing his fats very well, and now his hormones are back up. So unless he has that genetic predisposition, and when you see people with a genetic predisposition for hypertriglyceridemia or dyslipidemia, their cholesterol and their triglycerides are really fucking high. Not this minimal stuff I'm talking about. We're talking really high, and a lot of them have
Like 260, 270.
no,
Even more?
even more. And people with high triglycerides, really high triglycerides, or what we call familial hypertriglyceridemia, when you draw their blood, you see fat droplets in it.
Wow.
The fat actually rises to the top of the blood tube.
I have never seen that happen
It's
before.
pretty crazy. And they have that, and then they have, a lot of them have what's called xanthelasmas, which are little fatty deposits underneath their skin. You'll see that. It's pretty interesting. But that's the true familial type stuff. Those people, I mean, you've got them on the meds to lower everything, and they are more likely to have heart disease. They are more likely to have a heart condition, die from a heart condition, because they just have circulating fat. And what happens with circulating fat is, it's gonna clog up your arteries, for lack of a better word. It's gonna cause, they're gonna have scarring inside your blood vessels. They're gonna have embolisms, whatever. So they don't have the good outcomes. So when you see all these minimal minor numbers that you're gonna get exposed to, there's over panic. And why is there that over panic? Now you get to the real big thing that I really wanted to talk about is the conspiracy. That's what the problem is. This is all a giant fucking conspiracy. And why do I say that? Because rich are getting richer. Pharmaceutical companies are making hand over fist money. Specialty care providers are making a shitload of money. And you're just getting more and more shit cranked out. And what's my evidence of that? If I take this guy and instead of having the apocalypse, and I actually work on his diet, work on his exercise, and start eliminating some of these medications, I guarantee you, if he does what I say, he's going to feel better. Those medications are going to go away, and his numbers are going to get better. All without me using a
Then you're not going
shitload
to see him as often.
Exactly. But when I see him, it's going to be, let's talk about prevention. How's your diet coming along? How's this coming along? What can I do to help you keep from getting sick? Now our visits are prevention and wellness, not treating this problem that you had. Now my goal is keep you from getting sick, keep you out of the hospital, keep you from all those things that you don't have a genetic predisposition for. That's the goal. And really, what healthcare doesn't understand is you would make a better living off of prevention than you would off of the shit that we do now for treating for cures. And
you can do it with a clear conscience.
And you got happy patients. And you got patients that, guess what? More than likely are never going to fucking sue you. because everything that is done now is I'll cover your ass. Whenever I had patients where I would have this conversation with them and they're like, you know what, you're right, Beaveman, I don't want that medicine. Okay, you know what then? I will tell them, like, all right, what we're going to do now is I'm going to cover my ass because you still get, you still do insurance. I'm going to put in your chart that you and I had this conversation and you made an educated decision that said, I don't want this medication. You and I talked about it and I support your decision. Because all I did was have that conversation with you and we covered our ass together and said, hey, I agree with you. He made a decision. He's, he knows what he's doing. I support him. This is what we're going to work on forward from this point. And no one's going to be able to sue me. No one's going to ever come after me. Insurance is never going to say anything. It's the idiots that you work with that say, oh, no, you have to do this. Well, why do I have to do that? You're telling me now that I got to tell the patient what they have to do, and that's not how it's supposed to be. It's supposed to be I'm supposed to have an informed patient. I've seen providers get mad at patients for looking stuff up on the internet. I'm like, why are you going to get mad at somebody who's interested in their own health and isn't trying to figure out and is trying to figure out what's going on with them? I've seen providers flat out tell people bullshit lies about stuff that they just pulled out of their ass. And when the patient left, I'm like, you just totally made that shit up that you told them about the question that they asked. And they're like, yep. Because they just want to look superior to that patient. And I will tell you, why is it better? Why is it all still, like I said, it's still a fucking conspiracy. And what's my evidence that you can actually do what I'm talking about? I've done it lots of times. It's because people, if they are involved in their own health and they want to do it, you can knock this stuff out. But that's not the majority of patients, and it's not the majority of providers. But if you want to talk about the evidence also that's other than me saying so, all you got to do is read books from one of my favorite books that was written in the 1970s about the thyroid. The guy who was like the best with the thyroid, Broda Barnes, he was not, the test for thyroid, the lab test, they didn't exist. He treated people's thyroids based on their symptoms and based on their basal body temperature in the morning. And he was very successful. And I treat people like that a lot of times too. Because, again, it goes back to my training is different from a lot of the conventional training because I was always taught that you don't order a test unless you know what the outcome is going to be, and then is it necessary for you to do the test, and you treat people based on their symptoms, and you talk to people. That's how you treat them. But not everybody's treated that way. And why was I trained that way specifically? Because my specific profession was designed, or so they say, to work outside of the city, to work in rural areas. Because who doesn't want to work in the little country settings? The MDs and DOs. So who's working out there? Me. Because, they got to work where the money is. We were designed to work in these little rural areas where you don't have testing, and you don't have labs, and you don't have all those other things. So you're basing everything on your clinical skills.
See, that's what I don't understand, is that even in those rural settings, it's a hard word to say for me, seems like you can still make a pretty damn good living. Do you really need to, do these other big city doctors or whatever really need to gouge their patients in order to get by?
But what's the driving force all the time? Money's the driving force. What if, my driving force is satisfaction. I want to have a good conscience. I want to be satisfied with what I've done. I want to, I'll tell people, I've told students in the past, I'm like, I've taken care of children, mom and dad, grandparents, great-grandparents in the same family because they all came to me. I'm like, that's satisfaction. You know what satisfaction is? Knowing what the kids were for Halloween. Knowing who's playing soccer this year and who's playing baseball this year. Because you know what? When somebody gets sick, you learn more about what's going on in their life in regard to what's going on with that illness. Instead of me just guessing. I'm like, oh, well, they just got back from Mexico and they have diarrhea. Or they just did this and they have this.
And they probably drank the water.
Yeah. So that's all about getting that history. And there's a push out there to get rid of the history. Well, it's not necessary. We can figure everything out by these lab tests that we do, these diagnostic studies that we do. oh, we don't need to take this detailed history.
Well, I thought that was the whole point of going to school and learning all that stuff, is so you can be selective, so you know what to look for. You know, hey, diarrhea, that's a symptom of, possible parasitic infection or whatever, So then you know to run that specific test because the cause fits the symptom, and then when you confirm it, you can treat the cause and make them better.
But am I going to make more money by listening? Or am I going to make the company more money by doing studies and prescribing medications without having the results back?
Obviously, there's more money in the other way, but...
And what takes more time? It takes more time for me to do a thorough assessment and actually talk to you than it does for me to say, okay, your symptoms are what? Okay, I see that. Okay, so what we're going to do is I'm going to order this. I'm going to put you on this med, and go ahead and come back and see me in 2 weeks. Or not. I just did your visit in 6 minutes as opposed to 20. I just made more money. I can see more patients in an hour because I only took 6 minutes with you. And then I'm going to chart on you.
6 minute visit, how do you know if the patient's even telling the truth?
Well, in a 6 minute visit, what did you actually do? I've seen, I've worked in, areas where there's multiple providers. I've seen them go in and come out in less than, like 3 minutes and order a bunch of stuff and be done. And I'm like, what did you learn in that amount of time, really? You might have talked to them, but did you actually listen? And did you use any clinical assessment skills? I've been with lots of, providers, when I've, done agency work or had to go from place to place or whatever, by preference. And I've seen them never touch the patient, never use their stethoscope, never use scopes to look in their ears, eyes, nose, mouth, throat.
Something got brought up in a sociology class that I'm taking. One of the students said, and I had to hold back from gasping when she said it, math is not science.
Okay, how's it not intertwined with science the same?
Without math, there is no science. Period.
Yeah, so where is she?
Well, that seems to be where kids are going nowadays. Facts are not real facts.
Mm-hmm.
Facts can be made up. If they can't be mathematically proven, then one person can say one thing and another person can say another. And they can both claim they're right. But only one of them, or neither of them, can be right.
Well, we can't prove too much of anything because it's all still based on theory. Math is still based on theory.
1 + 1 is 2. Our limitation...
Per our understanding. You're talking about per human understanding.
Our limitations on our understanding of math is limited only by what we can mathematically prove.
Which is not much. So even if you say 1 + 1 is 2, 1 is 1/100th of a whole, correct? So what can you actually say? Well, I could say that 1 + 1 is equal to 200%.
The basic rules of math is that you reduce it to its simplest form. So
sure,
1/100th of a whole or 1.
Okay.
Same thing.
But still, it's only things that you still can't prove it. We can only prove it by our understanding of the universe. Just like, pi is an infinite number.
Or how about 1 and 0?
But they're not saying it. But they're not saying it based on the based on breaking it down the way I'm doing it. They're saying it based off of pure ignorance. You know what I'm saying?
Yeah, I think so.
I'm saying that yes, I'm agreeing them and only with respect, but that's not why they're saying it. What I'm saying is everything's theoretical for us, but we have basic rules that we follow that is correct to our understanding. So as far as we know, it's correct. We could be completely wrong, but by our basic understanding, absolutely, 1 + 1 is 2.
There is no logical, reasonable, or verifiable method in existence as far as human knowledge, the whole sum of human knowledge goes that suggests otherwise is even possible.
Correct. That's right.
Right.
But they're not.
So
but
to
that's
say,
not what they're basing it on.
Right. But it's the whole concept, and it's becoming, I think, more and more of a problem, is that people see facts where none exist, or they deny facts that do exist.
Mm-hmm. Well, it's because you're flooded with varying opinions and the fact that you can skew things. For example, back to the whole cholesterol thing, right? So if you have this low cardiac risk, this 10-year risk, is that calculator accurate? When we're basing it on studies that are about 30 years down the road or 40 years down the road, these long-term studies. Maybe at 50 years, it didn't ever matter. I can find just as many studies that support the use of a statin medication as I can find studies that refute the use of a statin medication. And why is that? Because statistically, if I want to have my outcome be correct, then I can make the statistic logarithmic. So we are flooded with so much information that we can find the result that we want personally if we just look. That doesn't mean it's right, but because we're so flooded with information that we can pick and choose what we actually think is correct based on our own opinion. And that's why I say, you can pick, I could take 20 healthcare providers, primary care providers, and throw them in a room, and I would say probably 2 of them agree with what I just said.
Well, that's why, and I was telling one of my teachers today that I think it's important that young people nowadays understand the difference between fact and truth. Because, and I'm not bad-mouthing the Bible. I'm
Here we go.
Me, but
Here we go with the Bible again. For some reason, we just can't get away from religion.
Yeah, well,
Every conversation we have.
The Bible has a lot of truth in it.
As far as we know.
But as far as we know, there's very little fact.
And that's reasonable. And why is that reasonable?
Because we can't prove it.
And
Everything that's in the Bible literally is hearsay that was passed down for 250, maybe 300 years of word of mouth before it was finally written down. But it gets even worse than that, right? Because it gets even worse than that because you're talking about translations. Right.
And differences in languages.
Right.
And then who's to say that even with translations that people admitted shit and there's like, that's not important.
Right.
Or whatever. So yeah, we are basing everything off of who knows what anymore.
So the 10 Commandments, for example.
There were 20.
Well, okay. Let's just use the 10 Commandments because most people understand it that way.
Moses used the original tablet.
Yeah, he smashed them.
No, I mean he had the original tablet.
Oh, yeah, computer tablet. Anyway, shit. Now I forgot what I was gonna say.
It's like, what were the 20 commandments? Thou shalt not shop on eBay. Use Amazon.
The 10 commandments may be true. It's good to follow the 10 commandments because it's bad to lie.
Well, because it's ethical.
But is it really a fact that that God literally wrote it down, or did He dictate it and Moses wrote it for him? We don't know. We weren't there.
Or did Moses just make the shit up himself? Because that's general. I mean, the 10 Commandments are general rules for being a good, decent human being that people should be ingrained.
And that is truth. And I think a truth is something that most people will look at and say, that is right. That's good and just and all that. But the fact, we don't know.
Mm-hmm. Well, and I think an interesting conversation that we could probably fill an entire podcast with also is that if heaven and hell don't exist, and you don't believe in any of it, then why aren't you why aren't you always cheating on your wife? Why aren't you a murderer? Why aren't you doing all these things? You know, I have lots of theories on that, but, you know, is it because it's not right ethically, morally, and that's what you're bound by, regardless of whether there's a heaven or hell or not? Or is it that you still deep down have that feeling or that sense that, well, I don't believe in it, but what if? What if it really does exist? You know, I can't really be that way because there is a possibility that exists.
I always look at it this way: whether you believe in God or not, it is difficult to deny that the Bible is a very good guide on how to live happily.
Yes, it is. Well, except for the Old Testament.
And that is truth.
Except for maybe the Old Testament. All right.
Well, I don't know. In the Old Testament, having more than one wife was okay. Some people would say that's cool.
Yeah, but it depends on the interpretation of that also, because apparently having more than one wife might have meant that they loosely interpreted the term wife. So somebody that was your girlfriend, somebody that would have been one of your wives, even though you were not technically married.
Right.
So yeah, it's all about interpretation. But once again, here we have strayed away into religion because it's Doc's favorite subject next to Dungeons and Dragons, which also apparently has religious annotations. All right, so maybe not as funny. I don't know. Mostly it was me ranting. But that was it. I just wanted to give my opinion on that. And I'll try to give my opinion also. I'll try to make the next one more funny. You know. But from now on, I've decided, and this is up to Doc too, because this is a 50-50 decision. I've decided not to tell anybody what our next episode is about from here on out, unless you really want to.
For a little while, I think we should try it that way. It'll give us a little more freedom if we come up with a better idea at the last minute to say, oh man, I really wanted to do this other thing, but we said we'd do this, so now we got to do that.
Yeah.
You know?
Yeah, and that's, assuming we have listeners anyway, so, But what you will have to look forward to is episode 6. I just put my hands up as a 2, but I meant episode 6. So
hey, if you wiggled your fingers like that, it could have been a quote.
3 times. Then it's 6. So yeah, the next episode, I don't know. This will be something fun. But yeah, periodically you'll probably hear me bitch about healthcare stuff, medical stuff. How I think it's a big fucking conspiracy for a bunch of fucktards to make a bunch of money and to have our population even less healthy than they already were. And I really think that we need to go back to the basics. We really just need to talk to people and figure shit out and stop throwing medications at everybody. That's a big no-no. And what really pisses me off is that all these people are trying to cite the reasons why they do it when you're being told, like antibiotics. The CDC says, stop fucking using antibiotics for every goddamn thing.
Well, how blatant do they have to be when they have a pill that costs $70 here in the States, and then you cross the border to Canada, and for some reason it's worth 70 cents?
Yeah, it's bullshit. It's all bullshit. That's why I say it's all, when my patients would bitch about these things to me, after a while, they knew better than to bitch to me because I would bitch right along with them. I'm like, you're bitching to the wrong person because I agree with what you're saying.
You're bitching to the choir. I mean,
exactly,
preaching to the choir.
Because then you're actually talking about together stuff, and you're saying they're not disputing with it. And they're like, well, shit, I can't argue with Beaveman. He agrees with me. So let's just talk about something else. All right, so that's our episode. Get your friends to listen. Hopefully you enjoyed it. That's about it for me. I will just, as usual, say adios, mooch fuckos. And to the Doc, I say anything you have to say, Doc.
Bye.
All right. Bye-bye.